Well, I want to first thank our patient, Mr. Pugh, and my nurse Angela, and Greg and Todd, who are here to help support this in-office case today. And so what we're going to do, we've already anesthetized Mr. Pugh. We've gone through the topical anesthetic and then the infiltrative anesthesia. So I'm going to show you a quick endoscopy of the nasal cavity. We're going to be treating the lateral wall. We're going to be treating a septal swell body, and we're going to be treating the inferior turbinate on each side. So I'm going to show you his nose. Now, if his nose would stay like this forever, we'd be done because he's wide open and the nose has been anesthetized and decongested. So it's going to look pretty healthy when we go in there. But I'm going to show you his left side first. And you can see where we've injected the valve here. There is the anterior end of the inferior turbinate, and there is the middle turbinate. And you can see where that swell body that was just discussed is nicely decongested, so you can easily see that vertical portion of the middle turbinate. And that's often my endpoint when I'm doing septoplasty, is to be able to see that. And so now we've got it nicely decongested, but that's the swell body that we're going to treat right there on each side. We're going to treat the anterior end of the inferior turbinate as well as the nasal valve. Now, Mr. Pugh has had a previous septoplasty. He's also had sinus surgery, but his nasal obstructive complaints have persisted. So we saw him, and he had obviously been on medical therapy. He used nasal steroids. They have not been helpful. He's tried the Breathe Right strips, which were a little bit helpful, but that's not a good long-term plan. No one wants to wear a Breathe Right strip 24/7. And so that was not an option for him. So when we saw him by examination, he had lateral wall collapse. He responded with a modified caudal maneuver, which was positive. He had large swell body. He had enlarged inferior turbinates. And they responded well to topical decongestion. So we discussed this procedure with him in detail, and so he's here today to go forward with that. So we're going to first treat the lateral wall. Now, I'm going to put a lot of pressure, and I think you've got a slide that shows you the treatment vectors, as we call them. And so when I'm on the lateral wall, I'm going to be pushing fairly hard laterally to the point where he might even feel like I'm trying to turn his head. I've told him not to turn his head. So he's going to sit still while we do this. But we're going to treat 3 areas on the valve on the left side. We're going to treat 3 areas on the valve on the right side. And then we're going to come back and do swell body and inferior turbinate on the left side and do the same thing on the right side. So we're going to use a little bit of the conductive gel that Dr. Fatakia talked about, because that helps with the conduction of the energy. So I'm pushing fairly hard here. You doing okay?
Doing good.
So there's a relaxation period of about 12 seconds after the treatment is applied. So the total treatment with each spot is 30 seconds. And I forgot to show you the most important thing I've learned. Right here. Lift up the armrest so you can get closer to the patient so you're not at an awkward angle. So I showed you the awkward angle only to show you a better way to do it now. So I'm going to treat the second spot just above it, so you want to try to avoid overlapping these sites. And we'll treat one more site inferiorly. When he was talking about the injection, I agree completely with that. You don't need a lot. Too much kind of distorts the area you want to treat, but not enough means they're probably not going to have a good conduction. But I would say the most important part of anesthesia is the waiting time. And I like to wait at least 10 minutes from application of topical anesthetic before I do my infiltrative, and then I'll wait at least another 10 minutes before we do the procedure. Doing okay?
Doing good.
I don't know if you can tell, but I got my hand kind of resting on his chin. Doesn't seem like it'd be hard, but to hold something steady for 30 seconds is not always the easiest thing. So just try to steady your hand when you got it in the right spot on the patient's chin, and you can hold that spot pretty easily for 30 seconds. So I've done two. I've got one more. I'm going to do the most inferior aspect right now. Again, I'm pushing out pretty hard. All right, now I'm going to go to the endoscopic portion to treat the septal swell bodies and the inferior turbinates. Doing okay?
Doing good.
So I can see that anterior portion, vertical attachment, the middle turbinate, and that's right where that swell body seems to be maximal. And as Dr. Fatakia said, you worry about treating corresponding sides of the nasal septum, although as we've done that, we haven't seen any septal perforations. There's still some perpendicular plate of ethmoid bone in there. And I like to put this in the direction of airflow, which is heading right towards that middle meatus. So I'm going to find the inferior turbinate anterior head, and I'm going to aim in that direction. Two more spots. Hanging in there?
Hanging in here.
Good. Clean my scope. So there's that vertical portion of the middle turbinate again. one more spot. We're going to treat this other inferior turbinate. Again, I'm going to aim towards the middle meatus, so there's the anterior end right there. All right, that is it. I'm going to clean a little bit of this gel out of his nose. I'm going to put a little ointment in there along the valve area. Let me show you the nose one more time. I'm sorry. Let's just do one more look. You can see the blanched area there. And you can see the inferior turbinate now, which before we couldn't, and that's from displacement of that aspect of the valve. Same thing here. You can see an immediate change in the appearance of the valve. So that looks good. All right, Dr. Fatakia, while I clean his nose up and put some ointment in, we can start with some questions if you'd like.
Great. Well, Dr. Sillers, please weigh in. I will try to remember to repeat the question. Somebody remind me. Again.
Yep.
At this point, we'll field any questions anybody has. We'll go from there. Dr. Guillory. Dr. Sillers, the length of energy that you're applying, the length of time you're applying the energy to the lateral nasal wall, the septum.
Yeah, it's 18 seconds at each treatment site. So you're in the nose for 30 seconds, and it's a treatment and then a relaxation. So basically you're letting the tip of the wand cool. I've not seen it, pull apart prematurely and cause any bleeding, but basically you're trying to let it just cool for that remaining 12 seconds of the 30.
Oh, I think the answer, please correct me from industry if I'm wrong, I believe the 12 applications, is that correct?
Oh, the total number of applications. Yes, yes. Yeah, so we did 10 applications.
Yeah. So up to 12 applications per disposable stylus. Yes, sir.
I'm gonna dismiss our patient so he doesn't have to sit here while we do the question and answer. And Angela too. Angela.
So the question, Dr. Sillers, is have you tried to reshape angulated septal cartilage associated with this?
I have not. I have not tried to treat deviated septum with this.
Yeah, nor have I. And it's a particularly interesting question because there are subtle deviations in the cartilaginous septum that would be wonderful if we could remodel, per se. Again, the important thing to remember is we want to be very careful with the cartilaginous structure of the nose, not impairing it. So I think of this as a soft tissue, which some people consider cartilage soft tissue, obviously by definition, but I think of this as a submucosal benefit. There is some energy that is applied to the septum, so it's not something that I do either. It is a good question, though.
Dr. Fatakia, if I can just say for a minute, after 25 years of practicing rhinology, in the last 2 years is really the first time that I've thought thoughtfully about the nasal valve because there wasn't an easy way to treat it. And so everyone that came in my office with complaints of nasal obstruction, the first thought that came into my brain is septoplasty, turbinoplasty. And I've done plenty of septoplasties and turbinoplasties for patients with nasal obstruction, and some of them don't get well. And what's been interesting to me is to see the patients with a deviated septum where we did this type of in-office procedure and they got better in spite of the fact of a deviated septum. So all that means is we've got to be better at trying to understand where the nasal obstruction is coming from. And I'm guilty of not having done that up until recently. And so I think this is a real opportunity to be better physicians, better diagnosticians, and then ultimately our patients have better outcomes because we're identifying their true cause of nasal obstruction. And I just, training as a resident, you just think, septoplasty, septoplasty, septoplasty when someone complains of nasal obstruction. And that's not always going to lead to a happy, satisfied patient.
I couldn't agree more. I think being able to look at yourself in the mirror as a physician, as a surgeon is hard. Sometimes the easier route is just to continue doing the same thing.
Yep.
But I could do process to provide more comprehensive, better overall care.
I'm Ulfred Jacobowitz from New York. I'm also, FYI, an advisor to RN Medical. I did the clinical trial prior. So anecdotally, I did use the probe on smaller areas of the septum, and I have seen a change in shape. So anecdotally possible. The question is obviously, the probe is not designed in terms of the surface area to treat a large surface area. But just from a few anecdotal experiences, I think it can potentially modify.
Thank you for sharing. Any other questions? So, Dr. Sillers, the post-procedure complications, crusting, I'll put my 2 cents in.
Sure.
As a presentation, compared to other radiofrequency applications, I find the crusting much less. There is some minimal crusting. Complications, we're used to at least considering bleeding as a complication. I can say that with this technology confidently, I don't worry about bleeding at all, to the point where I don't know what the industry wants me to say here, but I will feel comfortable doing it on patients that are on blood thinners or aspirin.
Yeah, and I also have not had any bleeding complications. The most bleeding you see is when you do your infiltrative anesthesia. You may have a couple of cc's of blood that comes out of the nose, and that's really about it. Crusting, though, when you treat more areas, you're potentially going to get more crusting. So when I first started, I was treating only the lateral wall. Had a little bit of crusting. When I've added inferior turbinates and septal swell bodies to some patients, they will have a little more swelling afterwards. So it's almost like I tell them, like I would a septoplasty patient, you're going to feel like you've got a cold for about a week. I have them using some saline spray. I don't think it warrants full-on saline irrigations, high volume irrigations, but saline spray is helpful. And we will get them a little bit of Bactroban ointment to apply to the lateral wall twice a day for that first week or so, as long as they're having some crusting. And that seems to keep it soft so they can control it and take care of it.
Any reports of septal perforation?
Not
that I know of.
Yeah, none on my end either.
And none reported either. Letting me off easy. All right. Thank you guys very much again.
Thank you.